Good afternoon, everyone, and thanks for joining in today. I'm Dr. Kim Newell Green, and I'll be the moderator for today's virtual Grand Round, which is entitled A Fireside Chat with California's top doc, Mark Ghaly, MD, MPH, who is the Secretary of California Health and Human Services. Next slide, please. Please do note our disclosures. Next slide, please. And this is our agenda for today. Next slide, please. Do note that, as always, CME is being provided. Just make sure to complete the survey that you'll be sent after the webinar and attest to your attendance so that we can send you your certificate. Next slide, please. So today marks a year since we hosted our first virtual Grand Round sponsored by the California Health and Human Services Agency and the California Medical Association. And I want to mark it by saying an enormous thank you to both of those partners for helping us engage such an impressive array of experts and for the thought leadership about how to bring the latest clinically relevant information on this COVID-19 pandemic to California's healthcare providers and other interested listeners. Special thanks to Dr. Alice Chen for spearheading this effort and doing the hard work to get it started, and Dr. Carol Glazer, who's been supporting us recently on the agency side. I also want to extend a special thank you to Dustin Corcoran and Lupe Alonso and their amazing CME staff at the CMA, who have done enormous amounts of work behind the scenes to support the seamless production of this series. Juliana Hinch, Dee Strobridge, Ariana Clark, Ann Engwer, and others have been fantastic to work with. This summer feels very different than last summer when I first sat here with you. There's no more obsessing about which color tier your county is in. People are traveling some and recreating more and enjoying the summer sun if they can avoid the heat. And yet, the pandemic still has surprises for us, and we're all wondering how many more tricks it has up its sleeve as we watch the Delta variant rapidly come to predominate the cases in our state and wonder about how to vaccinate the still vulnerable and whether we will need boosters. And so we've invited to today's webinar our usual guest and the amazing California State epidemiologist, Dr. Erica Pan, who will review for us the epidemiology of the disease, the progress of vaccinations, and the state of our COVID-19 variants. We'll hear from Erica for a minute, however, but we're going to start today with Dr. Mark Ghaly, now the Secretary of California's largest agency, Health and Human Services. Mark trained in pediatrics with me at UCSF at least 100 years ago, and he's always been an incredible colleague and friend, and most importantly, a powerful advocate for the health and dignity of the most vulnerable of all ages in our state. We're so grateful for Dr. Pan and Dr. Ghaly's incredible leadership during this time, and I look forward to hearing from them both. I'm going to get started with a bit of history about Mark, but I want to remind you to please submit any questions you have on this conversation by using the question box in the control panel. That's located on the right-hand side of your screen, and we'll go over your questions as time allows. Dr. Mark Ghaly was appointed Secretary of California Health and Human Services by Governor Gavin Newsom in 2019. Prior to this appointment, Mark had 15 years of experience in county health leadership roles, culminating in a role as the Deputy Director for Community Health and Integrated Programs for the LA County Department of Health Services. During these years, Mark has worked across disciplines and departments and broken down silos to integrate services and support for our most vulnerable populations in California, working in jail health, developing LA County's Office of Diversion and Reentry, which diverted thousands out of county jail and into community-based treatment and permanent supportive housing. He developed the Housing for Health program to support chronically ill individuals who are facing homelessness, and he's been an early leader in the Whole Person Care pilot program, among many other things. When Mark was asked to oversee the California's largest agency, which includes not only health, but all of the human service departments of our state, he was expecting to support the implementation of our governor's vision to expand health coverage and access to all Californians, and was planning to work across state government, along with county, city, and private sector partners to ensure that the most vulnerable Californians have access to the resources and services that they need to lead healthy, happy, and productive lives. And then we know what happened next. COVID-19 derailed forward-thinking programs, absconded the state's resources, and generally pushed us all into crisis management. So we're going to begin as soon as Dr. Ghaly arrives. He's had a very busy morning, talking to him about some of the issues that have come up in this unusual job he was faced with. I don't think Dr. Ghaly is with us yet, but Dr. Pan is here, and I'd love to invite Erica, you on so that we can ask you a few questions as we go along. I think one of the things, Erica, that's on people's minds, and you may address this in your presentation later, but people are wondering, what is this going to look like in the coming months and years? And I know, as usual, I always ask you to predict things that you can't predict, but given the rapidity of the evolution of serious variants and the inconsistent levels of vaccination at the global level, do we stand any chance of more normalization in the next year or two? How do you imagine our lives will continue to be different than in the pre-COVID era in the next 1, 3, 5 years?
Yeah, great questions. And as you're alluding to, we all wish we had the crystal ball, but I'm definitely happy to share kind of my perspective on all of this. I mean, I think in general, even before the most recent increases in the Delta variant specifically, which I can talk a little bit about now and in my talk, I think, the way I've been thinking about this current phase we're in is sort of the, mitigation suppression phase. And sometimes when you see phases of pandemics, you have these surges and then you have, you try to suppress and then you're going to have bumps along the way, right? And I think so I consider this next several months kind of part of that suppression phase. And the way we're going to get out of this pandemic, and I think we also don't have a great chance with this particular virus to eradicate it, right? It's going to be another vaccine preventable disease, but at least it won't be so devastating to have so much worldwide morbidity and mortality once we can get basically two key things have to happen. We still have 15% of our population in the United States that are not even eligible for vaccine yet. So that's our under 12s, right? So that has to happen. And of course, we need to make a lot more progress than all the people who are currently eligible. And obviously there are pockets and there are a lot of equity and other kind of progress we need to make. And then really importantly, and I know everyone knows this, but just to reiterate, and we need to get the rest of the world vaccinated, right? I think the latest is that it's about 10% or so, or maybe I saw something a little bit higher, but certainly variants are going to continue evolving the more transmission there is anywhere. And so until we really get our 100% of people eligible, or certainly everyone except infants or whatever small group we may not have, and the rest of the world, at least a lot higher levels of vaccination, we're going to still be in pandemic mode. I think we're doing a lot of projections for here in California, and thankfully, again, we got to really, really low levels in early June, right before we reopened. So we have a lot of runway, is one way I've been thinking about. Is really great. We got to really low test positivity, low cases and hospitalization rates. I'll show you some of those numbers later. So we have a lot of runway, but we are looking at, and I think we are going to see with Delta and the increase in surges. Do we think it'll be as devastating as last winter? In our sort of modeling scenarios, that seems extremely unlikely. But we could see something to, a half to 2/3 of what we saw last summer, kind of at the current projections that we're seeing. So we really need to continue to move the dial on vaccinations. That's really still our way out, and still we need to work a lot on access and confidence in vaccines.
Great, thanks. I was going to talk to both you and Mark about some things about what it's like to be a leader in this time. And so if you wouldn't mind thinking and talking to us about what it's like to be a public health leader at a time when public health officials are both beloved by many and also the subject not only of scorn and frustration, but sometimes are receiving threats. And what's that been like for you as a professional, and how has your family responded, if you even want to share that with us?
Sure. Yeah, it's actually timely to be answering some of those questions. I was just actually realizing I've actually now been in the state for exactly 1 year today. So July 13th, 2020 is when I was sworn in. Yeah, it's been incredibly challenging. On one hand, I was actually literally just saying to someone else recently, I love what I do. I love my combination of, pediatric infectious diseases and public health. And I've always loved that there's always something new around the corner and evolving and flexibility, but I am tired of this virus. And I'm tired of making, we had an interim after action report interview recently. One of the just sort of standard questions was, have you had to make any difficult decisions? And I just started laughing because every single day I feel like, or certainly every single week, there are really, really tough decisions we're making. And I feel really lucky on a professional level to have been able to serve at the local level and have, been one of the first to make an extremely difficult decision. Although many of us who made that first decision in the Bay Area, to do that initial stay-at-home order. Thought that was the hardest decision we would ever make, but actually figuring out reopening was even harder, right? I think we knew a lot of data about what we needed to do then, and there was a lot of data from pandemic flus in the past, from 1918, that we needed to do, and we felt really good, actually, that saved lots of lives, lots of hospitalizations. But I think the science and evolution around how to reopen most effectively, and especially with a brand new virus like this that really wasn't flu, and we've learned so much over the last year and a half about how different this virus is from flu. There's a lot of similarities, but a lot of differences. So I think that was even more challenging. So, and then to your other question about yeah, it is fascinating, I think, and really unfortunate how polarizing public health has become. I think on one hand, as public health officials, I'm grateful people actually know what I do. For a long time, if I tried to tell someone what I did, they didn't really understand. I could talk to them about being a clinician and my clinical work, but a lot of people just didn't really, what's a local health officer, and so for better or worse, people now know what local health officers are and what state health officers are. And I do, of course, just very personally remember being kind of very publicly antagonized as an unelected official. And I think it's really important that we're unelected, because even being unelected, obviously there's just a lot around these high impact, understandably high impact decisions. And so we joke sometimes too about, if we have just as many people unhappy on each side, that maybe we've gotten it right. but it is really hard. I mean, even just, of course, everyone knows, and we'll talk about it later too, that this week the issue du jour is schools and continuing indoor masking, and our inboxes are flooded, and there's a lot of antagonism going on as well. There's a few, but less vocal, that are supportive of this. But so yeah, it's incredibly challenging. And as far as it's been really challenging on family life, and I think that's really one of the hardest things too. I think early on, you can feel it's so important, but after a year and a half, it's hard.
Yeah. I can only imagine. Well, we're so grateful for the work you do. I think we have welcomed Mark on. So unfortunately, due to some technical difficulties, Mark has been unable to come on by video. Mark, are you here with us audio wise, at least?
Yeah, can you hear me?
We can, and
Okay.
It's really nice to hear a voice. And just so you know, I gave you a terribly wonderful introduction, so you can read it later if you want. But we've dived right into the questions with Erica, and I wonder if I can just dive right in with some questions for you.
Yeah, please do. And I'll be honest, I was enjoying listening to Erica's reflections,
Yes.
and grateful to have Erica having agreed. I wonder sometimes whether Erica would have agreed to take the job knowing what she knows now about it. I think she probably would have, because the impact, despite all of the hard work, is still really important to her, and I know the people around her. But I have to say how grateful I am that she's part of the team and doing what she does and leading the way she does. So thanks, Erica.
Oh, thank you, Mark. It's an honor to work with you. I'm really happy to have come to serve with you.
Well, Mark, I feel the same way about both of you. So maybe you can just kind of say what that's been like for you, because you joined the state at a time when there was a lot of hope for what big programs you could do to help our state provide healthcare services to everyone, especially the most vulnerable, with a governor who was really supportive of that. What's it been like for you to have to sort of show up for this crisis instead of the work that you were hired for?
Well, I mean, I think there's a couple of ways to think about that question. The first thing I say is I feel like this is what I was hired for, right? California's my job as secretary is to support what is, like, depending on how you look at it, 40 to 60% of state government, the departments and offices that I have the privilege of working with, including CDPH, where Erica works, and others. We drive a lot of the work in California, period, right? Whether it's on the social services side and support for young families and working families and food assistance, and then obviously all the healthcare work and public health and so developmental services. So when you have a global pandemic, even though we didn't know it was coming, it is what I signed up for in a way. So it's been a real privilege and gift to get to do it. But the emotions and exhaustion is real. I've always thought of myself as somebody who tries to be pretty even-keeled and calm in most situations, and this has definitely tested that. But all in all, the other way that I put it, and you know, in all transparency, Kim, you and I had these conversations as I took the job, and the enthusiasm I had for all of the amazing work we could advance for Californians. And I actually think the pandemic, in really uncomfortable but real visible ways, has allowed that to be an even greater opportunity. To know, everyone knows what this afternoon I'm joining the governor in announcing kind of the final chapter, right? Like, it's signed, it's moving forward. This roaring back budget of $100 billion that's being invested in so many different things. We didn't have that pre-pandemic. California, I know that the economy, one of the messages is the economy affects lots of different Californians differently, but as a state and a whole, we have a significant amount of resource right now to advance some of those programs. And no better time has there been than now to really push forward on things. And I really do think of our work as a safety net, right? And I've been talking about it as this opportunity, not just to tighten up that safety net and make sure people don't fall through cracks, but also to widen it and get more people served. And then, really importantly, to lift it up. Because we have so long with our health and social services caused people to fall so far down, nearly hitting the ground, but not quite, before the net catches them. And now we have this opportunity, whether it's on healthcare, financial assistance, food assistance, housing, other things, to lift that up and allow people to get services earlier so that they can be more likely to rebound and get on the road to self-sufficiency and better health, which I know all of my colleagues on this Zoom care deeply about. We also have an unprecedented chance. Equity, thanks to leaders like Erica and so many others, has become a household term. People know that we've been striving for equity in our response, imperfectly, behind the times, never faster than COVID, but still with real resolve and commitment to it, that we now have this amazing runway to continue to advance equity in a way that with resources, we're going to be able to do better than before the pandemic. And then the last thing I would say, which is a real amazing transformation, and I came into the job wanting to work on this, but not sure how we would do it, is bridging public health and physical health. And the work that all of you do in your clinics and in your clinical operations sometimes feels cut off from what is the core work that, for example, Erica did in Alameda, Tomas did in San Francisco. I had the privilege of doing some of it in LA. That there's this idea that these are separate things, but we've learned more than ever that this needs to be brought closer together. And I've always seen population health focus as a way to do that, but I think we have other tools now to have that conversation and advance it, because so many of the resources get invested in the health side, the physical health side, and public health strategies don't always get their inclusion and funding. But now I think we can connect these in a better way. So it's been hard, but the final way I would answer this question: if Governor Newsom offered me the job as Secretary for Health and Human Services, only if I would be willing to help lead a global California through a global pandemic with so many other all-star amazing people, just to get on the other end of being able to guide resource investments for our patients and our population, I would have signed up for the job in a heartbeat. So in so many ways, it's been a real privilege to do this for with all of you and for your patients collectively.
Amazing. Well, again, what a privilege it is to have you there sort of shepherding so much of this important work that so many people in our state are doing. I have so many follow-up questions from that beautiful answer you gave, and some of them tie back to some listener questions. Let's start where you ended, which is talking a little bit about public health. So given the critical nature of public health, one listener asked, what are we doing as a state to strengthen our freight system of public health to prepare not only for the next pandemic, but really all of the other things that public health does? And so my question to you is, do you view our public health system as frayed? Was it when you started? Is it stronger now, 1.5 years into the pandemic? I think you just said yes. And what will we be able to do? What concrete things right now are you working on to strengthen public health as a state and as a nation so that really sustainable, we don't forget about it when times seem good?
Yeah, I think it's an excellent question, and the governor has really pushed us in this budget, this monumental budget, to think about how do we not just invest in what we've always done, but how do we invest in a new kind of system? And California's public health system has been one where the California Department of Public Health plays a very important role, but a complementary role to things that local public health has done. And that whole notion has been tested throughout this pandemic, whether it's based on what guidance you have, how you do testing. I mean, you pick your thing, it has been tested. So I think where we are is, how do we dream big, not in the urgency of this moment, where COVID is still so front of mind, but we know we've fallen behind on things like STDs and disease surveillance and health equity in other ways, and chronic disease and all of these things. Like, that has unfortunately not been driven as hard. But I believe that through the really important planning that's already started under Erica and Tomas Aragon's leadership at Department of Public Health, along with many at the local level and others, that we can actually craft a set of investments that the governor and the legislature have committed to making, not just for COVID, but around things like health equity. Right? What are we going to do to take the equity metric that we refined and built into our blueprint for a safer economy that looked at test positivity county by county, and not just county by county, but hard hit communities of color versus less hard hit, often affluent white communities? How do we compare that and drive the level of openness based on that? Well, how do you take that model and talk about diabetes care or hypertension in the same way? So we have this incredible chance to reframe and recast how we approach this work, but you don't do that by putting money into the same old things that you've always done. I think this is a chance to invest in certain new things that I'm really excited to do. And as I said before, if public health is only dependent on its existing dollars, like the dollars that the traditional streams that fund public health, I think we're not going to get where we want to get. We have to bring the healthcare delivery system and public health work closer together to recognize that full advantage that I think California wants to see.
Yeah, I think that's really important. And over your career, one of the things that you've really been able to do is see the siloed work, all people doing great work, but in their own world, and imagine how to bridge them. And so can you even give us a concrete sense of what that might look like? I know it sounds like it's still in development, but
I mean, it's a very concrete thing. We talk about, you all work, many of you primary care providers out there, and even some of those who are in specialty care, you've worked in the medical home team model. We created this notion that it's not a doctor alone, it's not even a doctor and a nurse alone that get care to happen. We depend on others, whether it's for behavioral health or some of the social drivers. We depend on lots of people. I always cast people, I talk about the most important staff in the clinical places I've worked were the ones who walked to work. They knew before my day even started who was going to show up and who wasn't, based on what happened in the neighborhood on the, over the weekend. How do we lean on public health and this notion that the ability to get into the community and do real groundbreaking work, whether it's around contact tracing and vaccinations and testing, how do we leverage that capacity and ability to connect to augment what we do in our clinics? We don't have to figure that all out ourselves. Our colleagues, our clinical colleagues in public health are doing that day in and day out for other things. How do we put that on scale to help augment our clinical work? I mean, that's the kind of thing that I think California has a chance to really groundbreak on because of what we saw in the pandemic.
Yeah. Yeah, it's very exciting, and I can't wait to see how that evolves. Speaking of another system that you're really working hard to sort of identify in a different way, break down some silos and some separation. Let's talk a little about mental and behavioral health. We, of course, have seen lots of data that as a state and a country, mental health individuals of all ages has really suffered during the pandemic. And probably most of us think we're just seeing the tip of the iceberg. And behavioral and mental health was problematic before the pandemic. So I know that there's been a really exciting new funding for a behavioral health plan for youth, but we'd love to hear how the state's thinking about supporting the mental health of Californians. And perhaps you can tell us a little bit about the behavioral health plan for youth.
Sure. So, I mean, I think one of the most important things you said in that intro, Kim, is that this was a problem before the pandemic. The pandemic made old problems harder, worse, deeper on many levels. And behavioral health is true. The level of isolation for all Californians was higher. We learned and tried to connect in different ways, but it wasn't always perfect. And for some, it was worse. We saw that, as a pediatrician, I think Erica, Kim, we all saw the impact with our colleagues in children's hospitals across the state, emergency rooms that take care of kids, psych urgent care centers, hotlines and helplines of all varieties with increased quote traffic and need. So this is a tremendous chance to take a good chunk of $100 billion investment in California and say, let's make the California behavioral health system the envy of all folks. And what I really appreciate is that we didn't promise to do it in a year or 2 years. We said it's going to take a little time because this kind of transformation does take time. There's some immediate things. So schools will get some immediate help right away for young people. We've invested more in some of the adult systems of care. Our CalAIM program for Medicaid is going to bring closer together physical health and behavioral health, trying to treat, provide more services on substance use disorders than we ever have, trying to ensure that funding is enhanced and augmented through federal resources for some of those most costly services. But I think I'm most excited about the Children's Behavioral Health Initiative because not only is it nearly $4.5 billion over 5 years of investment, but it really says we're going to build a program for all Californians under the age of 25 where they shouldn't worry whether they're going to get the kind of care that they need. We're going to build up the workforce, both the formal clinical workforce and that supporting community workforce to get kids not just assessed early, but served early, using the virtual tools that we began to perfect in COVID and get better at here in this space as well, a statewide virtual platform where all kids can start to get support, their families can get care and support as well. And then recognizing the important linkage between what happens to kids and what happens at schools. These are not all school-based. These will be school-linked services where there's space and desire. They'll be school-based, of course, but we know not every school is poised to set up a behavioral health clinic for all of its students. So we're not depending on that, but we're working with our education partners to make sure that it's built up well. And then there's going to be investment in some of the things that we know are missing today. And I can tell you many stories of young kids who came into emergency departments with pure behavioral health issues, early psychosis, where we didn't get the care they needed because it wasn't available. And we sat and I would even say, we went through the motions of case planning, knowing that the unicorn bed was never going to emerge. And the sad stories of what happened to those young people and their families while they waited and waited and waited. Hopefully we create infrastructure where that wait isn't long. And more importantly, that the upstream pre hospital services are available more widely so those kids can get care way before they need 5150 or need to be restrained or need a locked inpatient bed. So I'm excited about where we can go with this, but I know the role of family practice physicians, pediatricians, all people who take care of individuals under 25 in your entire team. You're going to have to be shoulder to shoulder with us to make this a reality and make it as impactful as I think we all hope it can be.
Yeah, I think that and so many opportunities are very exciting. And so I'm super grateful for you and your team's planning on that. One of the other areas where you've quite a lot of experience yourself is in working with people who have been in jails and prisons, both youth and adults. And I saw data from a number of prisons around the country showing that prisons have had rates of COVID-19 that are eight to 9 times higher than the surrounding areas. That was just one article I looked at. I don't know the data well, but I just wonder what your view on this is. And of course, could we have managed that differently in our state? And what have we learned from that experience? And maybe how are you thinking about codifying our experience so that next time we can do better? What would be required to change the outcomes? Is that legislation? Is that more resources? Is that education and training? Tell me more how you think about those congregate settings.
Yeah, so I think it's a really excellent question. And I know early on, we all had worries and our heads went to certain populations. All of us do, right? I'm worried about so-and-so. Many people were worried about our oldest Californians. And I think that was very appropriate. I certainly was worried about jails and juvenile detention facilities and prisons, and frankly, places like state hospitals where you didn't have an alternate care site per se. You couldn't move people around. They were constructed in some of the worst ways possible for an airborne infection like COVID. And the truth is, we didn't quite know what we know today back then. And so when I think about how we could have done things differently, certainly I wish we would have been clear-eyed about how COVID is transmitted and instituted certain things earlier. Some of the movement of people from facilities to facilities we thought were actually COVID protective, and they were actually what wasn't, what actually started facilities that were COVID free from now having the beginnings of an outbreak. And this thing is sneaky and quick, and it spreads quickly. And we learned that in some of our prisons, and I know lots of jails learned it. So I think on a number of levels, it's to make sure we have stronger and better infection control practices in jails and prisons and places where people aren't voluntarily there. And we owe it to that community and population. I think that there's a lot of work that needs to be done on strengthening the healthcare services that are routinely available to our inmates. And I think that there's a lot of people on the Zoom who have made a commitment either with their entire clinical career, portions of it, to strengthen that. But now I think we have a new set of conditions that we have to plan on. I have no doubt that in the next 3 to 5 years, legislation will come forward that will try to strengthen the protections for inmates from, pandemics like COVID. And we will be changing that. But I also think it forces us to ask the question, how do we use confinement in jails and prisons, especially for people with complex health conditions, to advance public safety and public good? And, we have now a lot more experience with releasing lots of individuals back to their community and doing it safely. And so how do we think about those plans and those under the gun decisions and think about what might continue forward so that, tying it back to the behavioral health question, it's no secret that some of the failures in our community behavioral health system have manifest in jails and prisons becoming behavioral health clinics. I often say that the courts have become our new mental health clinics because that's the truth. People with behavioral health conditions are more likely to get caught up in the justice system for a number of reasons. And so how do we examine the investments that we're making to hopefully find that fewer people whose confinement in jails and prisons are driven by their health conditions, that we have a different answer for those populations. And I look forward to working on that with many of you in the years to come.
Thank you for that. It's such an important issue and one that I know you care deeply about. And really it alludes to, again, the issue of the most vulnerable in our state. And you talked before about how this pandemic has really laid bare some of the deep disparities that exist in our state and nation, and people of color and vulnerable populations have really suffered inordinately. So I'm just curious, in this series, we've been grateful to hear a lot about state and local efforts, committees, policies, funding, outreach to improve the equity of care and of things like testing and vaccination during the pandemic. What's your sense of how much these massive efforts have helped, and what methods do you feel like have been successful, and maybe which ones haven't been so successful?
Well, I think I remember one of the earliest talks I ever gave in a position of leadership was about how all healthcare is local. And I think about our strategies. We talk about the ground game and the air game, and we talk about how they're both really important. But if you force me to pick one, it would be the ground game. And that's because I think this work happens when people get on their knees and have hard conversations and important conversations. And I think we did so many things well, but we often talk about that last mile. And that last mile of work is about working with disenfranchised, historically overlooked communities. And the easy part is the first 90%, but that last 10% is often so critical and critically important and hard. And so I find the things that have been most impactful to support and serve those who've been most likely to fall through the cracks or remain invisible to us are those the real ground game. So door knocking, some people have been they don't think it's the right thing to do. It's absolutely the right thing to do in certain communities, and it's the only thing that works. Erica is always so good at sending around data. She did it again this morning or last night. Frankly, part of what makes Erica so amazing is she is tenacious with how much she does get done when most of us are sleeping. And she sent around some very helpful information about what communities that are not getting vaccinated really think. And it flips on its head some of the things that we thought were working. And it's all these not personal, you think you can cookie cut us into something kind of approaches. They just don't work with hesitant or questioning communities. And so many of our communities that have been historically shouldering burden and disparities are those. So I think the thing that I think has worked is when we get on our knees and do the ground game really well. And I think the things that I look forward to continuing to invest in the immediate and the long term are going to be those sort of strategies. And it's no accident that I mentioned that as when you said, what is the actual example? Like one is that, like, how do we get the clinical world more connected to community without having to do it all ourselves, right? Who's doing it well and how do we link up with them? So I think that's what I sort of see as a path forward, and making investments in that space is helpful.
Well, I have questions to last all day, and I recognize you're going to probably need to leave us pretty soon to go do other important work. But I've been thinking about really both of you for the past, Erica for the year and you, Mark, for a year and a half, about the burdens placed on decision makers like you during an unprecedented crisis. Can you just tell us what that was like for you, and maybe just briefly talk about something you've learned about leadership in a time of crisis, and from your own leadership or from watching those around you leading in this time?
You know, this isn't going to be earth-shattering, but like humility there's no replacement for it. I have become a much better learner and listener. Erica, don't answer that question. She probably is thinking like, man, if he's better now, I hate to see him beforehand. But really, it's like, how do you surround yourself with people who are gonna give you the best shot of coming up with the best answer in a lot of uncertainty? And then how do you constantly approach the decision with confidence and humility at the same time? And we've pivoted. I mean, people talk about the pivot, and is it a quick pivot? Is it a sharp pivot, or is it a gradual one? I mean, they're all pivots, because this idea that we constantly learn, and that's what I've said. I want to be the state that learned the most and learned the fastest, because we all got it wrong early, like we do on every other health problem. Right? And we didn't have a playbook. We didn't have an instruction manual. There was no game film on COVID. But today we actually have some game film. We know what it does much better than before. Still unpredictable. So I feel like what I've learned and tried to emulate and bring to our decisions, and I'll just talk about one in specific that I know resonates with Erica, because it was among the hardest, was the first stay at home was easy in relative nature. People were ready, they were compliant, traffic stopped, things stopped happening. Many of the things that we shut down, we wish we didn't today, right? Like, I think the school issue, we've learned a lot. Kids, we certainly want kids back to school, and that's manifest in the decision now, getting kids back to school, sort of as tenaciously as we can get. But that regional stay-at-home order, that second stay-at-home order in November, was so hard, and I think so critical. And the data shows it. We made meaningful changes to people's movement patterns because of it, and I think probably shortened the winter surge by some time and saved lives that would have been lost. So, by way of gratitude to Erica and her amazing leadership in that, and so many others, Alice Chen, another, Hernando, the number of docs, but then the number of non-docs who helped on that, incredible. People who had no training in public health became very important, salient players in these decisions. And I think it was helpful to have a really humble approach. And this isn't hopefully self-promoting like I'm some super humble person. That's not the point of it. But the point of the statement is, like, humility matters, because otherwise you're in deep trouble. Because we've made lots of decisions that, we could have said that differently, or done it at a different time, or done it slightly differently. And I think we've learned a lot from it. The other thing that I've learned, and Erica says this, hears me say it a lot, let's avoid boxing ourselves in. We boxed ourselves in a lot. We thought it was the clear, better way to go. And then a month later, people are not as forgiving as you hoped they would be. So another lesson is, don't box yourself in. I remember a reporter asked me sometime in October, they said, well, I remember in April you said this. I was like, in April? You're going to quote me from April? I mean, if what I said in April was that good and that standing, I'm better than I thought I was, right? Like, there's no way. So, I mean, just this constant frame of learning and being humble in the face of a lot of other people helping show you data and information, I think is what I've learned in this. Erica, you probably have a more eloquent, concise answer to it, but certainly how I see it.
Mark, do you have time for one more brief question?
Yeah,
brief, depending
sure,
on how you answer it. We asked Erica a little personal question at the beginning, and I know you to be someone who's so extremely dedicated to your family, to your wife, who's also an extremely accomplished health leader, and your 4 children. How have you managed that balance during this time?
It's been hard. It's like the kids, I mean, look, kids went through a lot, regardless of what your parents did. But we are fortunate to have resources that allowed our kids to have the best shot through this as possible. But it was hard. I mean, I have to thank thank God for the amazing partner I have in Christina. She is will always be my sung and unsung hero for what she does and how she supports this family and me. And it went both ways. Like she had her moments as well, and it was a lot of fun in some ways working with her and thinking about some of the shared challenges. Some of the work in LA was really impactful. I think the state did a lot to come support LA in a really dark and tough time. And that was easier to do because of my linkages and understanding and support from Christina. But, it's hard. It was really hard. And I have to say, like, yeah, we've done a good job protecting them against so many things, and they've learned a lot. But we still worry and get concerned, and the time away from them and missing a lot of their development, because I still live in LA and commute, and there were lots of weeks where I didn't get back, and those were hard. But the last few months have been really special, even though the days are really long. Being able to see them for 5 or 10 minutes and congratulate them on something they did or talk about something that didn't go their way has been a real gift to have back. And so who knows what comes ahead, but I'm just grateful that we've gotten through this part of it so far, and they still they still love me, and I get the stories are hilarious though, right? The 7-year-old Eli, who has absolutely no filter, he threatens to call the governor directly to tell him I quit. And then the 11-year-old discovered that the governor wouldn't believe a 7-year-old's voice for mine, so they decided that they might just text him that, because how can they tell who did the text? So we'll see. But so far, we've been blessed to get through it all.
Yeah, well, thank you for that candor. I know that so many of us, myself having children and families, so many people on this call who have been working so hard through this pandemic and have really maintained their professional equilibrium to the extent that we all can in this really very difficult time. We're grateful that you're here for that, and super grateful that you could join us for today. As usual, I have many more questions from our audience and personally, and we would love to invite you back someday, hopefully, but in the meantime, go off and do the important work that you're doing, and thank you for it all.
Yeah, Kim, can I just say one thing? Because I think this tees up, if Erica is going to come, I know you were, is it okay? Just, today kind of went off the rails, to be honest, because we had planned, I really wanted to be here for the whole time, and I'm not saying this as by way of excuse, but just to tell you all as clinical leaders, kind of what we're up against, right? We talked about getting kids back to school. We put forward a plan that we think aligns with the CDC, importantly, to get kids back. And now we spend so much time trying to clarify and ensure that the message is out there effectively. And one thing, Kim, if we had more time, I was really excited to talk to you about was just, our ability to communicate as scientists and clinicians and health leaders. I think that the med school of the future, the public health school of the future, really needs to spend a little bit more time on this. I remember my patient doctor class, and that was about communicating with patients at the bedside, and I learned a great deal. But how do we have a sort of, population doctor class where we're talking to our communities in effective ways? And I think this is one where, for better or for worse, I get to be one of the voice pieces along with Erica. But I hope all of you will just think about how you can help amplify a message around the importance of continuing to think and get our kids back to school over the next couple months. Some of you who take care of kids may be more natural, but I also think those who take care of adults and grandparents and others, this is an opportunity to just emphasize what a key part of our strategy of getting through this it's going to be. So hopefully that tees Erica up if she's staying on for a little longer to talk through some of the challenges we're seeing on that.
Mark,
All
thank
right,
you for bringing that
I'm going to leave now. Promise.
Okay.
Thank you, Kim, as always, and everybody else for tuning in. Take care.
Bye, Mark. I'll just comment on that, and I don't know, Erica, you don't have to comment on this. You can just go right to your presentation if you'd like. But we have had several people, and I agree with this notion, asking about whether we have had the assistance of people like behavioral economists and communication specialists from maybe outside health, helping us figure out not only, how to ask people to do these very hard things, and then also how to communicate it. So that feels like a very important learning from this. And it's that sort of multidisciplinary thing that we need to think about as humans trying to manage human behavior to keep everybody in a community safe. So with that, Erica, if you want to comment on that, great. And if not, we'll just start your slides and you can tell us what's going on in the state. And again, we're grateful for you to be here.
Sure. Thank you. And Mark is much too kind. It's been so great to work with him. And I can't remember if it was mentioned earlier, we did overlap during residency at one point too. So it's been really fun and inspiring to be here working with him again. So he's too kind, but it's been great. I think that last piece about, behaviorists and, what Mark mentioned that I had circulated last night was really some deeper dives into that kind of thing, like focus groups, really, kind of thinking about different, priority populations where we're seeing less vaccine confidence, and really interviewing them and trying to get more intelligence on that. And we've been talking a lot to the one behavioral person we do have who's been trying to do that, and to some other themes that he brought up as well. We're trying to, this entire time, this pandemic and this virus have really, just the scale and the magnitude and the pace have just continued to, push all of us. And so, typically, there's more of a cycle where you can really do that work and survey people, do focus groups, and understand what motivates them, and then use that in your communications. And then, but it takes time, and often we don't have enough time. Although I do think absolutely, especially moving forward, and how much sort of fatigue there is, and how much divisiveness there is about just basic public health interventions, masks, vaccines, all of the public health restrictions we had. We continue to need more of that. And it is something, I think, another theme, just to kind of respond to some of the themes that got discussed already, are really having broad stakeholders kind of involved to think about not only the impacts, but how different things are going to land on them. And just to help you see that lens and getting that buy-in to help. I think we did learn a lot as a clinician and public health community around two of the other laws, just remembering about medical exemptions and personal belief exemptions, right? And really, it sounds like the more successful way was to really get a parenting group to go along with the doctors in the white coats and the legislators to really talk about and campaign. And I think that's become even more clear during this pandemic. So, and the private sector does this quite a bit, right? And we've seen this in other public health versus private sector resources as well, whether it's sugar, beverages, tobacco, right? Other kind of, and the private sector resources this, and we haven't actually typically resourced public health or the government sector as much. And so I do think, and it is something we're looking at as we talk about taking this opportunity, as Mark was mentioning, and as you were asking about, to think about the future of public health and what do we really need to resource more. And there's so many things, data, IT, but behavioral health, absolutely, and being able to have more experts and more resources to really understand what are the modifying, motivators and modifications. But actually, to bring that full circle and then sort of launch into some epi and all of you as this audience, I do think much of our survey data, and hopefully many of you have seen this as well, and maybe a future theme for one of these, is that, a direct primary care provider is certainly one of the most trusted people that people cite when we're surveying them about various things, whether it's vaccines, especially vaccines, but even other public health interventions. And, we asked them about the CDC versus state public health or local public health, and really the resonating factors that all of you as the frontline providers are much more trusted, which makes sense. It's about humans and relationships. So we do want to continue to partner with CMA and other provider organizations to work to help have aligned messages and be able to get good messages out to really motivate people. So with that, yeah, I can sort of try to walk through just kind of what is going on with overall epi in the state, update on variants, our vaccination progress, because it's also, been a high interest topic, myocarditis and peds vaccination. And then of course, as we've talked about a couple times now, the school's guidance can touch on that as well. Next slide. So wanted to kind of harken, I think this was basically the last time, or certainly when we were doing our best as a state, but I think also maybe around the last time we had a grand rounds together, and we were one of the few states that had the lowest, blue is the lowest in the CDC levels of community transmission, the first to get their lowest case rates, lowest test positivity. So we were doing great in early June. Next slide. As was a lot of the country, and now we're kind of back to yellow, and then I'll talk about other trends. But and you can see there's huge surges happening, and right next door here in Nevada, but in other parts of the country as well, and certainly again in pockets of unvaccinated people. So we have already seen a big shift in the last month or so. And of course, the two big things that are happening in California are we reopened on June 15th, and then on top of that, we've seen increasing Delta, which I'll talk about. Next slide. And this is just our standard kind of dashboard, but just to talk through some key points just as far as trends. Actually, maybe I'll skip over. Let's go to the next slide. So here's kind of from April 1st through July 12th. So I showed you, again, early June was probably our lowest level of cases. And then we also have these sort of benchmarks where you can see, we hit 50% of 16 and older fully vaccinated mid-May, and then 60% mid-June. And again, reopening happened June 15th, as you all know. So now we've seen this sort of, we had a nice nadir, but now we're seeing increases again in our cases. Next slide. And then more concerning, we definitely anticipated increases post-reopening. And increases in cases, but we're also watching really closely is hospitalizations and new admissions. So, again, our hope is that we've done a much better job vaccinating our elderly and those who are at highest risk and who we prioritize vaccinating first. And we've seen patterns in the UK where their cases went way up, but their hospitalizations have been more steady. We are thankfully, again, we were at such a low number. We reached a nadir of under 900 hospitalizations per day in mid-June, but those have increased by almost 75%. Currently, we're at about 1,450, 1,500. Again, thankfully, it was a really low number, so we have a long runway before we're gonna get into any kind of healthcare capacity trouble, but our new admissions have doubled in the past 3 weeks as well. And the median age of hospitalization has decreased from 61 to our current median age of 53. And then this trend here on this slide is kind of by region. So the purple is Southern California. So LA is absolutely seeing the most increases in a lot of Southern California. And then you can see our other urban areas are where we're seeing kind of more of the increases as far as Sacramento, and the Bay Area, and then San Joaquin Valley has been a little bit more steady, and then our rural northern is, of course, there's just smaller numbers there in general, but has been pretty steady so far. Next slide. And then the other thing, we've been continuing to follow closely and to show you, when we look at seroprevalence, we're doing quite well as a state. So, this is a 4-week average for the date range shown here. And overall for California, it looks like 86%, which is pretty incredible. I will say a lot of caveats to this. This is our last publicly posted data, and we're going to have a pause because there's been a lot of decreased, along with having sort of a blood donation shortage and drop in testing, there's been a drop in the volume of data coming from the blood banks. And so our estimates are probably overestimates of true seroprevalence. And this, of course, doesn't distinguish between people who've been vaccinated versus prior infection. But of course, the steady increases really were associated with vaccination. But this is, and you can see our confidence interval ranges here too. So we think overall, over 80% Again, potentially a little bit of an overestimate. We've done a lot of weighting to look at different factors to try to take into account. A lot of our data is from clinical testing, and that's probably why it's an overestimate. And then the blood bank, which still has some biases on who comes to donate blood, but is more neutral as far as symptoms or other reasons people are getting that antibody test. So this looks like we're in good shape, but again, it's really important to see where the pockets are of lower seroprevalence, which right now this is really at a much broader regional level. We're doing some other projects moving forward to do ongoing seroprevalence surveillance. Next slide. And then another really interesting kind of thing to see is that all of our healthy places index quartile groups saw large increases in seroprevalence since December. Since February, when we really started ramping up our vaccinations, we've seen the steepest increase. And we saw the steepest increase in our sort of highest healthy places index quartile, are the most sort of resourced people. But when we look at it broken down by quartiles, we do see that as of June, more than 60% of people in all of these quartiles have detectable antibodies. So that's really encouraging as well. And it has closed the gap actually, interestingly. So we saw, again, and it makes sense, right? We saw our most disproportionate cases in the lowest quartile early on, so they had some natural immunity, and now we've sort of leveled that in a different way. But the data from the last few weeks are definitely subject to more uncertainty bias. Again, we had a lot of declines in testing volume and blood bank data as well. Next slide. And then, of course, of huge interest, I know everyone wants to know what are we seeing as far as variants. We'll have another update on this later this week. And this is looking at trends. So the epsilon was the one we were calling our West Coast, or some people were calling our California variant. That was the most predominant one early on. So that's the orange. And then as the alpha variant, or what we used to call the UK variant, started increasing, the epsilon started going down. And now you can see delta starting to increase and sort of replace the alpha variant. So delta is that gray line. And the last we looked, it was over 43% sort of statewide. And then in most, again, of our, actually I'll show you next slide. You can see the proportions, and sorry, I know the letters are a little small, but it's Bay Area, Greater Sacramento, Rancho is the rural Northern California, San Joaquin Valley, Southern California, and then overall California is what these 6 panels are. So you can see kind of the shift in the proportion of the dominant variants over time, which is a pretty interesting way to look at it. And so the yellow is sort of the Delta plus going from the bottom up. And then the next kind of teal color there is another Delta plus. And then this darker green is the overall Delta variant. So you can see, again, overall in California that we have, as mentioned, over 40%, and then seeing more of the plus in Southern California and the Bay Area. And the lowest region is that rural Northern California, but really on the increase everywhere. Next slide. And so, the common question also is, well, how are our vaccines doing against specifically the Delta variant, and what do we know or not know about this? So this is a really nice summary slide, and we took a deeper dive talking to our Western State Scientific Safety Group about this last week as well. In general, I think we try to use antibody as a surrogate, both for, as I just showed you, seroprevalence, and also for individuals to see if there's neutralizing antibody as a surrogate of immunity. But as you all well know, there's also all these other components that are really important for immunity as far as our T cell response, memory B cells. So this is a surrogate, but we still don't have, reassurance for sure that antibody neutralization is exactly the right surrogate, and people might still have good immunity, T cell immunity, that doesn't show up in their antibodies. But that being said, here's what we know about the Pfizer and some different links to the different outcome measures. So looking at hospitalizations, and a big theme, I think, really to stay, and hopefully you're hearing this elsewhere as well. So our vaccines are all working extremely well to prevent hospitalizations and deaths. They're doing their job as far as that goes. And even for the Delta variant, we're seeing over 90% preventing hospitalizations and deaths, and in all the sort of data we've been seeing. I think what we're seeing increasingly of concern, both in the data, and I'm sure many of you are hearing more anecdotally as well, is for symptomatic disease or asymptomatic disease as well. But this sort of, I'm not going to read through all this for you. And then the unknowns about, or the questions about Janssen or Johnson & Johnson at the bottom here. For that, we don't have any actual clinical data yet that we've seen, but we have seen really reassuring data in antibody neutralization of Delta in vitro, similar to the Moderna as well. So we are feeling good, again, about these are doing their job to prevent hospitalizations and deaths, and I'll show you later kind of a comparison of vaccinated versus unvaccinated rates. But we are seeing lower numbers, actually, than the data that's not on here is the recent Israel data that showed 64% effectiveness to prevent symptomatic disease or asymptomatic disease. Next slide. And then this is just progress in California, how we're doing over time. So the top lines are our proportion covered with at least one dose or fully vaccinated in blue for our over 65 population. So, again, thankfully we have over 70% of our 65 and over are fully vaccinated, and even more than that, closer to 80% with at least one dose. Overall, of our eligible population, we're at 60% fully vaccinated, and just around, just hitting the 70% as well of the 12 and over. Next slide. So this is a really nice, and we're going to try to get this out more publicly as well, but post-vaccination COVID-19 confirmed cases. So when you compare, well, first just to tell you, so we look at our over 20 million people that have been vaccinated. We cross-reference that with our database of people who've been tested positive for SARS-CoV-2. And so we've had around 10,000 post-vaccination cases reported. That's only 0.05% of the people who've been vaccinated, so extremely low. And then of those, a very, very, very low proportion have been hospitalized or deaths. And we're doing a deeper dive on the deaths to see, we don't have some of those that have been reported and tested positive may or may not have had COVID being the primary reason contributing to either their hospitalization or death, so trying to tease that a little bit more as well. And then when you look at cases, hospitalizations, and deaths based on vaccination status, you can see, again, the sharp decreases over time. I've been showing you different ways we've nadered, and then the steep increase in the unvaccinated. So that's what that green line is for the cases. And our case rate in unvaccinated right now is over 6 cases per 100,000 per day. So that's getting close to what we used to have in our purple tier in the blueprint. But you can see, again, our vaccinated population is staying steady, although a little bit of an increase there in cases. And then there's a little bit of an artificial tail at the end of the hospitalizations curve on this one. But again, we're seeing largely hospitalized cases are unvaccinated versus vaccinated. And there's a little bit of a time lag delay in that most recent couple of weeks there. And this is actually another area where we really want to actually appeal to all of you, as far as those of you who are hospitalists or have patients. We really need people to report their hospitalized cases, because we have incomplete data, especially there's a lot more time lag between getting more of the details on our hospitalized cases. And then again, deaths, of course, you can see there's really a really dramatic difference between vaccinated versus unvaccinated there. Next slide. So what are some other approaches that we are trying to do kind of and encourage, working with local health departments to improve vaccination? One of them is what we're calling halo immunization, or some of our colleagues are calling it buffer zone, but really trying to make sure, capitalizing on the moment when there's cases or outbreaks to then offer vaccination. Because as we all know, again, many of these conversations that need to happen, and many of the young male adults, for example, that are not getting vaccinated just are sort of the invincibles. They don't really think that they're at risk or that COVID's going to impact them. So really trying to do more proactive offering of vaccination to people who are exposed in an outbreak and their household members. So not just the exposed, but the people who are living with them as well. And that can really, it is sort of addressing a hot spot. It's important to, as a community, make sure we're not calling this post-exposure prophylaxis, because the incubation periods, don't work out. You're not trying to prevent infection from that initial exposure, but really just trying to improve and prevent infection moving forward in that community. We're hoping that community members may be more interested again in vaccine during an outbreak. So there are lots of things health departments and providers can do after unimmunized contacts are exposed and their contacts. So here's just a list of kind of different options to be thinking through. And this is sort of a combined audience of working with our local health departments and others and other healthcare facilities and providers on how to approach that. And again, try to have another opportunity to improve vaccine rates. Next slide. And then as far as pediatric vaccination, we're really spending a lot of time focusing on this, both now to get more of our 12 to 17-year-olds. We only have over half of our 16 to 17-year-olds with at least one dose, and over a third of 12 to 15-year-olds with at least one dose. And we saw a big sort of push for parents like myself who are, chomping at the bit to get my kids vaccinated, but we're plateauing a bit. We really need to continue to move this dial. So we're enrolling more primary care providers. Again, all of you on the front lines are the ones that people are trusting and having those conversations. Also coordinating more community, mobile, and school-based clinics, and launching, kind of really getting geared up to think about school-based clinics and bringing vaccines to where people are this fall or winter when we get under 12-year-olds approved. We also really we're leveraging our existing Vaccines for Children network that is well established, and identifying other partner organizations who can support expansion, including breaking down these large shipments into smaller shipments so that smaller providers can get vaccine. But of course, that none of us want to waste vaccine, but we also don't want to have any missed opportunities. So really trying to be clear that it's worth opening that vial, even if it's at the end of the day, to get people vaccinated. Every vaccination is making a difference. So next slide. And then to shift gears also and just talk about safety monitoring. I mean, we're really, again, lucky in the United States to have an amazing safety monitoring system. These are 4 of the key components of it. Most of you have heard of VAERS, the Vaccine Adverse Events Reporting System. The Vaccine Safety Data Link is actually a lot of different key locations in the country, but 2 of them are actually the Kaisers in Northern and Southern California. So we're really lucky here in California to have really rich data and attention to vaccine safety through that. And then CISA project stands for the clinical immunization safety. I forget what the A is for, but it's really every time you're having kind of a adverse event post-vaccine that you want to have a deeper dive, like after you report to VAERS, so deaths are being looked at that way. Certainly this is how we got a deeper dive on looking at myocarditis. So that's a common system where the primary provider who took care of a person who's vaccinated who had an adverse event that was afterwards trying to help investigate and determine if it was any causal effect or not, and just gather more of that data to help look at the whole picture. And then vSafe is something to encourage all your patients to do after they get vaccinated, to sign up on their phone so they can log in when they get a prompt to talk about any symptoms they're having over time, to help us look at vaccine, both the immediate, any side effects, and moving forward. Next slide. So with these, excellent safety monitoring systems, that is how we picked up signals for myocarditis, and how we picked up early signals for J&J as well. But to focus on myocarditis, so ACIP, as many of you know, met a few weeks ago and really looked at what data do we have about myocarditis, and what are kind of the benefit risks. And so there's a lot of great slides. This is a link to look at some of the discussions there, just highlighting a few here. But this kind of tries to outline for every 1 million doses of mRNA vaccine, given current use exposure risk, how many hospitalizations are prevented and how many compared to how many cases of myocarditis. And just to highlight one of these, and again, these slides on that link will show you, they break it down by these different 12 to 17, 18 to 24, 25 to 29, and by male and female. For one of the age groups we're most interested in, for 12 to 17-year-old males, probably 57 for every second dose vaccine, 5,700 COVID-19 cases prevented, 215 hospitalizations prevented, 71 ICU admissions, and 2 deaths. And then the trade-off there is in the 50 to 60 range of myocarditis cases, and also thinking about prevention of MIS-C, prevention of long COVID, and protection against variants. So those are sort of the data fields that the ACIP looked at and continuing to monitor very closely how much myocarditis we're seeing. Thankfully, most of them have been self-limited, as opposed to a lot of the longer term and more serious outcomes we're seeing with COVID disease itself. Next slide. So, and just trying to highlight again, as they interpreted and synthesized, looking at that data, really they looked at both individual benefits of vaccination versus individual risks, and also kind of at that broader population level. We think the benefits are likely an underestimate. Their analysis was performed using reported rates of cases and hospitalizations. There's a lot of uncertainty, especially in young adults, in baseline rates of myocarditis and in these rates of myocarditis after mRNA vaccines. I think as we continue to gather more data, we will, continue to have more sort of narrower confidence intervals around that. And again, like everything else, the balance of the risks and benefits varies by age and sex. I think because 12 to 15-year-olds were the most recent to be approved for EUA, that's going to be the place we have the least data. So continue to monitor that closely. But the signal is much higher in the 16 and over right now. Next slide. So shifting gears, I do want to address, and I think I did show this slide or a version of it last time as well, but to really kind of help all of you understand how we've been thinking about this at the state level as far as our schools guidance. So, we didn't have vaccines last year when we were thinking about schools guidance, and there's a lot of different public health tools, right? Always we talk about these layered strategies, layered mitigation. So vaccines, again, are our most important sort of for every setting, community-wide and elsewhere. And then we've been able to use testing, and we were able to use that, prior to vaccines as well, and certainly both making sure people who are symptomatic get tested, keeping them out of school, and then doing screening testing is another way you can really do frequent testing to kind of both monitor what's happening in that school community and again, detect and keep people out. And then as far as preventing in-school transmission, our tools that we can use are masks, ventilation, physical distancing, and stable groups. And what we're always trying to do, and actually hearkening back to an earlier theme that Kim was asking about, are, we're just trying to always balance, right? You're trying to balance what are the public health interventions you can do that have the most impact, that are the least socially disruptive, or least disruptive in this case in schools. And what we've been hearing loud and clear from our school partners is that physical distancing was preventing many kids from having full in-person instruction. And we've also learned the challenges, and especially those of you that are parents or are close with other educators, know how challenging even hybrid learning has been. So knowing that physical distancing in two ways is not the highest priority of what we want to prioritize here in California. It was preventing kids from being fully in person, and knowing that this is a disease that is largely airborne. It's droplet and airborne, but really there's some falser sense of security too with physical distancing. And really what we want to do is emphasize the layer of masking and making sure, again, schools are doing as much as they can around ventilation as the priority, along with testing and vaccination to keep kids in school. So that is sort of a lot of why and where we landed in California on universal masking indoors. We really want to get our kids back in school. We know that we're seeing these increases in Delta. I showed you the increases in hospitalizations, but we want to be able to use all of these tools to keep kids in school, even if some of the rates continue to go up. We know based on all this data from other communities that had maybe high levels of community transmission, but had all these other interventions in place in the school setting, that you can really continue to minimize any in-school transmission. So that is sort of just some background on and some of our thinking behind, because the CDC guidance, yes, said that fully vaccinated teachers and kids, so masking is optional. But we also know that it's really hard to, one, verify, and two, that there's a lot of, because masks have become so divisive, we didn't want there to be opportunities for, a couple of things. Administrators and teachers don't necessarily want to be the ones that have to enforce that. And then there can be, stigma in either direction, depending on the community, if you have some of the kids masked and some not masked. So really, to get our kids back in school, we wanted to emphasize these as the key tools. And then we're going to continue to reassess. It's really at the very front of our guidance. We have said we're going to continue to assess this on an ongoing basis, and no later than November 1st, reassess where we are. We, of course, know, especially for the 12 and older, where, over time, if community transmission is low, if there are other ways to think about, vaccination status, et cetera. So we'll continue to reassess, but really wanted to just have some guiding principles that would be consistent and clear to, again, make sure we get kids in seats. And then the other really nice thing that is new actually for schools guidance this fall is that there's more data from a couple different states about people wearing, if both a case and people exposed are both wearing masks, and especially if you can do testing on top of that, that you can also keep kids in school. So there's a modified quarantine, basically, that if both the person who is the case and the contact are wearing masks, and they're, we try to sort of describe too that they're, wearing them, using them appropriately. If both are wearing masks, you can actually allow the exposed to stay. It's a modified quarantine, so they can still come to in school. They'll be quarantined from extracurricular activities or other things, but again, trying to really optimize in-person instruction after seeing what's happened with our kids over the last year and a half without having that in-person instruction. So that's another nice thing that having universal masking buys us. It buys us, we've heard a lot about the disruption over the last several months of once there's one kid in a class who's a case, or a teacher who's a case, and the entire class is quarantined and has to go home. So this is really going to prevent a lot of those out of school days, and especially with testing, we'll still prevent in-school transmission, but allow kids to be in person. So I wanted to spend a little time trying to talk through that, and I'm imagining with Q&A there's going to be some questions around that too. Next slide. Just quickly for these last few things, I realize we're getting short on time, but I think since I last talked to all of you, we did issue our digital vaccine record. Here's the main website. We've uploaded, I think, something like 1.3 million people have successfully gotten their vaccine record. We hope this will be, a tool that people can use if they, don't want to carry around their little odd-sized card. It does have that QR code. I think over time there's going to be other apps that can incorporate that verification into wallets and things like that. And there's also on that website, if you're having issues, sometimes it's a minor misspelling or there's some minor issues that might mean your record is harder to find or your kids. But if you go to that website, I think we have ways you can troubleshoot and let us know what the issue is. And then there's teams actively continue to try to look up records and find out what the problem is to get you that verification. Next slide. And then vaccine equity efforts. So just trying to highlight again, we have 4 main strategies as far as increasing public awareness and education, encouraging vaccination, encouraging convenience, and accessibility. So those are all things we're doing. We prioritized 12 local health jurisdictions where 85% of people who were in the least healthy places index quartile 1 for the state lived, and really did a deeper dive there. And did an impact assessment approach and some initial learnings that different combinations of these levers and resources are going to be effective depending on the community or geography. And there's just some examples on this slide of things that have been done, whether it's clinics at trusted sites, whether it's with a faith-based organization or schools, doing door-to-door canvassing, making sure there's walk-in availability and outside, normal hours. And of course, language is always incredibly important to make sure we're reaching various populations. Next slide. And then also just additional work on our campaign. Next slide. So, we were touching on this earlier as far as the research that we've been doing that we want to continue to do, but trusted messengers are really important. So family and friends, and again, all of you as primary physicians or medical professionals that people know and already have relationships with. And vaccine motivators believe that vaccines are safe, effective, and were well tested. People who want to return to normal are also motivated by that. Seeing family and friends and gathering safely. A lot of the barriers we're finding in our surveys are that people are still concerned about long-term side effects and unknowns. There's some great talking points from Paul Offit around this to say that really in vaccines in general, any major side effects have been determined within the first 2 months after vaccination. So we need to continue to get that message out. Believing that vaccines aren't needed if you're in good health. Believing it was developed too quickly, really trying to emphasize in our communications that this is built upon decades of research. And of course, there's just a lot of trust issues as well with government, and that people have the right not to get vaccinated. Those are big barriers to people who are still not signing up to get their vaccine yet. Next slide. So our campaign focus based on a lot of that learned information is getting more and more surgical with the use of our vaccine administration data to see where we have our lowest numbers by zip code or census tract, continuing to work on our equity measures, preparing families for vaccinating children, again, gearing up for this fall or winter, and then, continue to prepare for unknowns around variants and boosters as well. Next slide. So we are working on a medical professional program under development. So we'll be definitely wanting to partner with CMA and others on outreach on this, and make sure if you don't already receive our Vaccinate 58 weekly e-newsletter, it has all of our upcoming tools. We just developed a rural toolkit for those of you in rural areas and really trying to resonate more with those communities. So there's a lot of great things there, a lot of youth toolkits as well, and other resources that you can use both for written materials, social media, and other things like that. Next slide. And more links for providers here. And I think that's finally it. So sorry, I didn't leave much time for other questions, but hopefully that was helpful.
So helpful as always, and thank you, Erica. I would love to, and maybe we'll even go over by 2 or 3 minutes and keep it recorded so people, if they have to go, can listen in, and if that works for your schedule, Erica. But let's do some rapid fire questions that people have had that are sort of very exciting, or people are really interested in. First of all, you talked about the PEDS approval, and I had read at some point that Pfizer was hoping to apply for EUA by September, depending on the data they're getting on these studies that are being done. But then I read that some members of the FDA aren't sure that we should approve a pediatric vaccine with EUA status because of sort of some benefits and risk thing. Have you heard about that, or do you have any sense of whether that approval is going to be difficult to get done? And I say this because I do agree with you that the benefits of pediatric vaccine are probably underestimated, because hospitalization isn't really the only morbidity of this disease for kids. The mental health impacts are massive in pediatric population, and those of us who do care about kids may be able to do some advocacy in that regard.
Yeah, no, great question. The latest I have heard is more about September. It's true, for a long time it felt like there was going to be enough data collected and that Pfizer at least was going to likely submit in September, and I did hear just in the last couple of days that it might be a little further out than that, and have heard less about this concern about whether or not it would be approved. So still hoping and thinking that it would be this winter, fall to winter.
Great. And what about, are you hearing about whether the vaccines are going to be given full approval in adults instead of still operating as under an EUA?
Yeah, that of course is a really important topic, and hearing kind of mixed sentiments around it as well. I guess typically FDA full approval usually does take 1.5 years or longer. And on the other hand, I think my personal perspective is, but we have vaccinated over, 150 million people in this country. So we've never accumulated this much data this quickly either. And again, there aren't really histories of long-term effects of vaccines. So I do think there's some advocacy going on around that. Some people have also been saying, we were talking to our Western States group about this recently, and yet again, another nuance on these things is that of people who are waiting to get, they don't trust the vaccine until it's approved, but then if the process is sped up so much more than the usual, then will that undermine the kind of confidence in the process? So I think that's the other thing that's out there. I do hope and think that they will, expedite this and move it faster, but I have not heard how long it's going to take. They've been very, it feels like there's not a lot of information coming out about that.
That's what I figured. I'm very careful with information, as probably they should be. And what about boosters? A lot of people are asking about how you at the state level and nationally, people are thinking about boosters.
Sure, yeah, and I was realizing I was talking about the Delta effectiveness, that when we brought together the Western States group, it was actually about both of these things. And of course they're kind of related, like what is the effectiveness we're seeing currently with Delta, and do we need boosters? And so we brought the group together to review some of the studies I just showed, and what's out there. And I think the bottom line is we at the state and that Western States scientific group kind of agree with the recent statement that the CDC and FDA just come out with, that there's a lot of great data being collected right now. It's too early really to say if and when they will be needed, I think. And there's again a lot of mixed sort of thoughts around how well our memory cells will work, our T cells will work. So I think waiting to see more data. I have heard there's going to be a reassessment of a lot of that data that's being collected, probably this fall also, like September, October. So hoping that, you know, ACIP and FDA and others will have more data to at least reassess and provide more updates then.
Right. And what about, you know, that we're getting a lot of questions about how to manage the immunocompromised and medically vulnerable. And, you know, we've seen in the news that Israel is giving boosters to some of these populations. And so I just wondered if you're having those also conversations at a state level, and recognizing that this is really the purview of the FDA to allow for these things, but wondering if our state has any, if there's any precedent for, you know, our state has been more strict often than the CDC, as we're seeing in the school masking guidelines. But can we sort of say, look, we think this third best booster in certain subpopulations is important, and we'll do it even if the FDA hasn't approved it? I'm talking controversy.
Yeah. No, it's a good question. I think we always want to be poised, which is again why we convene the Western States group to have, you know, we're so lucky not only in California, but then these colleagues in Portland and Washington, Nevada, to be looking at the data also with a critical eye with a group of experts. And I think that is the other thing in general, that I think if and when boosters are recommended, it's very likely that they will recommend to be prioritized in people with immunocompromised systems or the elderly. I think right now we did sort of have discussions about that in the last sort of week, and think it's really too early to make those recommendations. I think it's just too early to know what is needed. But looking forward to seeing what other data comes out of the UK and Israel and elsewhere.
Great. Another thing, a number of people are asking as owners and practitioners in offices, are there, I don't know this, maybe it's up on the state site, but what are the current recommendations about healthcare workers in offices? Are healthcare workers now recommended to continue masking all the time in the office? What sort of extra sanitation should people be doing, knowing what we know about COVID now and with the prevalence and vaccination rates that we have?
Sure. So in backwards order, as far as sanitation, disinfection, we are trying to get our kind of equivalent of the CDC FOMite brief out. Right now, our recommendations and the Cal OSHA recommendations are, if there's a known, like confirmed positive in a space, then that's the time to absolutely disinfect and not just clean. Otherwise, I think routine, you know, cleaning and disinfection is good to prevent all kinds of infections. And then we're trying to do a little bit of a crosswalk because it is, you know, we acknowledge it's a little confusing. There's Cal OSHA ATD standard, Cal OSHA ETS for employees that are not necessarily at risk of occupational exposure from a direct patient, and then just general healthcare settings. So in general, the rule of thumb right now is we're still sort of recommending that masks be used, you know, in all these healthcare settings, but trying to do a crosswalk of some of those important questions you're asking about. If it's an office building related and it's administrative and everyone's known to be fully vaccinated, then, you know, then people could be maskless in that setting. But so we are trying to work on a little bit of a crosswalk to help with that, because we do acknowledge it's confusing. I will say, you know, more and more with Delta variant, and what we're learning and concerned about is, I alluded to this, but you know, the role of the vaccinated in transmission. Again, I think vaccines are doing a great job, over 90% keeping people out of the hospital and deaths. But it does look like there was another New England Journal household transmission study, even pre-Delta actually, to show that vaccinated persons definitely transmitted less to other people, but it was only about half, 40 to 50% less than unvaccinated. It wasn't like 5 to 10%, which is what I think with earlier data and earlier thoughts were. So it is, you know, I think certainly in levels of high community transmission, especially, I think it makes sense to have more universal, you know, masking. I know Fauci and others have said that, and we're definitely taking a look at that as well. So I think if you think you're in a high risk setting, it's always the safest thing to do to mask, and it's pretty easy to do. We got used to it, right? So I know many of us, you know, we're tired of it sometimes, but again, it's one of the most effective and least disruptive tools we have. So.
Right. Great. Well, I will leave you with that. We have many more questions, but we'll see you soon. I will mention to our audience, first of all, thanks for sticking with us for so long. We are not going to have one of these sessions in August. We are taking a summer break, but we will be back in September with a very exciting presentation. Dr. Pan will be back along with another special guest. I really want to thank Erica and Dr. Ghaly for presenting today's content, and thank you so much for listening as always. I do want to let you know that California Department of Public Health and pediatric specialists across California are having 2 free webinars providing the latest information and clinical guidance on MIS-C, a really important condition to understand in pediatrics. So the space is limited for that, so please register as soon as possible. The first session is going to be July 28th. And just remember, you'll be sent a survey around 5 today, attest to your attendance, and you will get CME for this important information. Thank you, everyone, for a wonderful year, and have a great day.